I'm here today with Dr. Mike Osterholm, the leading infectious disease expert in the world, and came out with an amazing book, Deadliest Enemy: Our War Against Killer Germs, that I recommend everybody get as we kind of are dealing with, COVID-19 now. I would love, Mike, if you could introduce yourself and tell us a little bit about what's the current epidemiology of COVID-19.
Okay, well, thank you all very much for being here with you today. First of all, let me just say that what we know about COVID-19 obviously is changing by the day. Just by way of background, I've been very actively involved in working in coronaviruses. After 9/11, Secretary Tommy Thompson, then Secretary of HHS, asked me to come and split my time at the University of Minnesota and as a personal advisor to him on the issues related to post 9/11 and bioterrorism. So I happened to be there when the SARS outbreak happened in 2003, and so I worked extensively on that particular situation. Also then in 2012, when the MERS outbreaks first started occurring in the Arabian Peninsula, I served as an advisor to several of the governments in the Middle East on the Arabian Peninsula, and actually spent time in the Middle East working on MERS, the Middle Eastern Respiratory Syndrome. And in 2015, when a large outbreak occurred at Samsung Medical Center in Seoul, Korea, as a result of someone coming back from the Arabian Peninsula, bringing the virus with them and infecting several hundred people in that hospital, I also was in Seoul working at Samsung Medical Center in that particular situation. So I've had that experience in that regard. Also, I've been very actively involved with influenza work for a number of years, dating back more years than I care to talk about, and recognizing that there are many epidemiologic characteristics that are similar to this that also play here. Our group, which tracks these infectious diseases and publishes on them, I would urge all of you, this is all free of charge, there's no cost. If you want more information, you can go to our website, www.cidrap, cidrap.umn.edu, and we publish news stories every day. And we started covering this in the end of December of last year, recognizing something was happening in Wuhan that we thought might very well be coronavirus activity, but more like the SARS-MERS model, which, as I'll mention later, is quite different than what we see with this coronavirus. It became evident to us by the second week of January that what was happening in China was not classic SARS and MERS, where people are most infectious 5 or 6 days after onset of symptoms. But this was approaching much more like influenza virus-like transmission. And on January 20th, we actually put out a document to a group that we advised, the CIDRAP Leadership Forum, that this was going to be a worldwide pandemic, and it was just a matter of time before it unfolded. On February 3rd, we put out a document basically saying that because of time it took to have a new generation of cases, meaning if I transmitted one person to another, how long would that be, which was about 5 days. And on average, we already were getting this sense that people transmit to about 2 other people per person, which actually is a very large number in the infectious disease business. Regular flu is about 1.4, pandemic influenza is about 1.8. So we realized to go from 1 to 2 to 4 to 8 to 16 to 32 cases, with about 80% appearing to be mild to moderate, not requiring hospitalization, it would probably take about 5 to 6 weeks before we'd start to see cases really show up in meaningful numbers that could be detected. So we actually put out on the table that probably the last week of February, first week of March is when we'd see all this transmission occurring that actually had been occurring but just missed. And well, you know the rest of the story. In fact, it was the last week of February, first week of March that all happened. Those areas that had the virus seeded in early, such as Seattle, likely New York, clearly Italy, and Iran, were places where the virus had been transmitting for at least 5 or 6 generations. And when you start going from numbers like 500 to 1,000 to 2,000 to 4,000 in 20 days, then you start to understand the dynamics of what's happening in these places that are literally on fire. And the fact that in other places we've seen only limited activity, it doesn't tell us at all that they won't eventually, over the course of the next several months, not have similar activity, but that in fact this is not unexpected. We actually predicted this also, that we would see hotspots emerge right away. terms of what's happening in Asia, I just want to come back to that because it's very instructive to what's happening in the rest of the world. And first of all is the fact that, as we have predicted also there, we're beginning to see the resurgence of cases in Korea, in Singapore, and in Hong Kong. And trying to keep this virus suppressed is really, really a challenge. I mean, you can knock it down, you can hold it down for a while, but unless you keep very stringent population distancing measures in place, etc., you won't keep it that way. Even in China, as populations continue to be released in Hubei province, in Beijing, and even parts of Shanghai, I think that in the next 3 to 4 weeks, you're going to see a resurgence of cases back in China. They, of course, will be on top of it, unlike any other country. And at that point, in terms of how many cases, I think that still has to be determined. In terms of the rest of the world, it's now in at least 169 countries. And in each of these areas of the world, it's spreading more and more every day. This is one that is acting very much like an influenza virus pandemic, with one exception. We don't quite understand what's going on with kids. And what I mean by that is children are clearly getting infected, but there are very, very few clinical cases with that. With influenza, kids are a real major source of transmission in the community. They're kind of like little virus reactors, and they take the virus, spread it among themselves, take it home. We're not seeing that here. In terms of the case fatality rate, it varies, but very consistent in the sense that if you are older, if you have underlying health conditions such as smoking, diabetes, you have chronic lung disease, renal disease, and are likely obese, these are all overriding risk factors that can very much determine what the case fatality rate is. It was estimated in China to be between 3 and 4%. That compares with seasonal flu of 0.1%. However, in a place like Seoul, Korea, it was below 1%. But why was that? In Seoul, Korea, the outbreak was initially focused on a very large religious sect of more than 5,000 people, and that the average age of those people was about 40 years. It was a very young group, not many of the very serious complications that we see with a population in Italy right now, where it's at 7% case fatality rate, and over 80% of the deaths are in people over age 75. So each one varies by where it's at. In China, men who smoke over age 70 had a 12% case fatality rate. So it gives you a sense that you have to look at the underlying population. In our country here in the United States, we're very concerned about this because we have a lot of people living with high risk factors. Let me be really clear, while the majority of severe illnesses and deaths are in that older age population, younger cases can occur. Today in LA, it's widely been reported about an individual less than 18 years of age has died. Those are very rare. In Korea, there still has yet not been a death in anyone under age 40. So in that sense, I don't want to minimize these in cases. They're surely more than numbers. They're real people. They're our families. They're our loved ones. But on an epidemiologic basis, this is clearly a disease affecting older population. Now in New York, which is literally on fire, there's widespread reports of the fact that many of the cases are under age 50, between 30 and 50. And that's a testing artifact right now. Who's getting tested? The testing that we have is so inadequate to really define what's going on epidemiologically because it's just so few tests available. What really is defining the outbreak is, to a certain degree, who presents to the hospital needing severe care for severe illness, and who also at the same time are in these complicated states that are more likely to have comorbidities that also contribute to their death. When we look at the deaths right now, one of the challenging situations is that on average, the case from the time that they develop something until they die is well over 3 weeks, consuming a great deal of healthcare service needs, and that's a challenge. As far as one other risk factor that I think is absolutely critical, one that is getting some attention but not nearly enough, and that's healthcare workers. In China, at least 4,600 healthcare workers were infected, a number died. In Italy, there have been at least 5,600 healthcare workers who have been infected, a number have died. In the United States, we are so poorly prepared for this. We don't have stockpiles of what we call N95 respirators. the very important face protection devices that we clearly need to keep this virus out. And I worry desperately about the number of cases we will see here in the United States and healthcare workers who will both get very sick and some who will die. It's interesting that the healthcare workers' cases overall have been sicker than non-healthcare worker cases, and not any way we could associate with underlying health conditions. And we believe that in part may be due to the fact of the dose they're getting. These wards, these rooms with patients in them, is literally swimming with virus, and so they may be getting a much, much larger dose. Where is this going to go from here? First of all, I don't have any hope at this point that there'll be seasonality. Hope is not a strategy anyway. And the fact of the matter is that why is that? Because SARS had nothing to do with seasonality. We finally ended SARS in June of 2003, and that was because it took us that long from the time it emerged in February to understand this idea that people weren't infectious till 5 or 6 days into their illness, that if we got them isolated so that they didn't infect others, that we could do that. We got rid of the animal reservoir, the palm civet type of a mammal that was sold in the food vendor locations of the markets for Guangdong province. And so we stopped pinging the population with new virus, got rid of it, it ended. With MERS, the camel population of the Arabian Peninsula is the primary reservoir. I can tell you that we're not going to put down 1.7 million camels in the Arabian Peninsula. And so the number of people getting infected continues year after year. Our main job is really not stopping that, because that's been difficult to do, is to make sure that these people don't transmit to others in healthcare facilities. I have literally sat outside a hospital in Abu Dhabi when it was 110 degrees, and there was a raging outbreak going on inside the hospital, as well as the fact that there were a lot of cases in the community. So, that part doesn't speak to seasonality. If you look at influenza, just as a model, it's a different virus, but there surely are similarities. I just want to remind everybody, yes, seasonal flu does occur in each of the respective hemispheres, but most people forget that influenza occurs year-round in the tropics. It's there all the time. In addition, if you look at the last 10 influenza pandemics, the emergence of a new virus that has occurred, the 10 last pandemics in the last 250 some years, 2 started in the winter, 3 started in the spring, 2 started in the summer, and 3 started in the fall. And every one of them had a big peak about 6 months after the original start. In 2009, that pandemic, which emerged in early March through April in Mexico. In North America, we had our big peak from mid-September to mid-October. It was very warm. So again, I just want to share that I don't think anybody who tells you that this is going to have a seasonal relationship like we see with flu viruses, they don't have any data to base it on whatsoever. In terms of what I see happening over the next few months is that we're going to see these rolling outbreaks that are going to occur around the world, and that they will continue to happen. Some may very well get as bad as we're seeing in New York, Iran, in the areas of northern Italy, etc. And we're just going to be living with it. Mitigation measures of social distancing, as it's been called, I like to call it physical distancing. I hope we don't ever get socially distant. Surely are the only tool we have right now, and it's not really known how effective those are. If you look at the 1918 data, they had at best marginal impact. So while everyone's employing them right now, we don't know what they're going to do. Where do we go with vaccine and drugs? And vaccines right now are all in the works. Anybody can make a vaccine for this. Trust me, I could do it overnight, but it doesn't mean it's going to be safe and effective. And it's going to take a lot of work to show that. And everyone is doing everything they can to move it as fast as possible. But I think if we even could show soon that a vaccine worked, it'd be at least 18 months to get it licensed, to get it produced, to get it into people's arms, long after we're going to see a lot of peak activity here. We have a little more hope for drugs in the sense of a potentially faster timeline, but even with drugs right now, we have to be very careful. It's not just that they work, but how toxic they are. One of the leading drugs that everyone was putting a great deal of hope in recently was withdrawn from further study after 13 patients all got the drug, and it was highly toxic. So I think at this point, we're still really into the public health interventions as being a key piece of what we can do. So with that, I think that covers a fair amount of the overview. I'm more than happy to address specific points, answer any questions you have, and go from there. So I hope that's what you're looking for. So fire away.
You were talking about the medication. What about chloroquine phosphate?
Again, all medications are on the table. I have real concerns about the toxicity of that particular drug as people might be using it. It's not an antiviral drug. It's basically modulating the immune system. And there's some reason to believe early in the immune system response, we want that immune system to be up and running. Whereas later in the illness, when we're potentially dealing with acute respiratory distress syndrome, we want to downregulate it. So I think it's a very fine dance we have with this drug. We may actually doing more harm initially and only more good later. And so I think all these drugs are there. Let me just say that when you hear all this optimism out there, please be careful. I chair 5 different working groups for the World Health Organization on the R&D roadmaps, research and development roadmaps for Ebola, Lassa, Nipah, Zika, and influenza. And I can tell you that several years ago, it was gospel truth that ZMapp, a type of monoclonal antibody, was a drug of choice for Ebola. It had been used extensively, all kinds of anecdotal data that how good it was. But then we actually had an outbreak, as it was only recently been curtailed in the DRC of Africa. There was actually a double-blind controlled trial conducted, and ZMapp didn't even finish in the top 5 drugs. It was not at all effective like people thought. So we always have to be careful from anecdotal reports, which often can be erroneous, to those of a situation where it actually works.
So are public health measures actually working? Are quarantines working? What is and what isn't? And if you were the ultimate decision maker in charge, what would you actually implement?
Well, first of all, when you ask, are they working, there's 2 components to that. Are they working in the immediate time period, but do they work long term? In the end, if I can postpone something now, but in the end it doesn't make any difference because the same numbers still get infected, that may actually be a benefit if it's a healthcare related condition, because 100 cases presenting to an emergency room tonight needing hospitalization are going to be very different for that institution than if in fact 100 cases present but 10 a week for 10 weeks. And so delaying cases can be a strategy that's still very important. But the modeling data that's been done by several groups, most recently reported activity was that from Imperial College in London, a group that really is well known for its work, found that basically unless you continue to suppress this virus for the entirety of the time until you get a vaccine, basically cases would come bouncing right back. What's what we're seeing in Asia right now. So I think the challenge is, what is our game plan? We don't have a national strategic plan. We're pretty much going from press conference to press conference in what we're deciding to do. The challenge is, do you want to shut down society and suppress it and hope that limits the transmission? Or do you want to do nothing? And then the other side of the house is that we will see a major flood of cases. We will overwhelm our healthcare system. We will cause a lot of collateral damage, meaning the people who have heart attacks or need acute care for asthma attacks, automobile injuries, et cetera, even having babies, are not going to get the care that they need. That's a very serious issue. Healthcare worker cases will skyrocket because of the conditions in those hospitals at the time. That's another option. I don't think that any of us believe we should really go there, although I've heard people recently saying, well, if it's old people, let's just get them out of the way and move on, which appalls me. I think there's a middle ground. I'm very involved right now with a group we're leading out of our center to try to develop a national policy statement of what would the strategic and tactical objectives and goals of a national plan look like. It might very well include the fact that we integrate back into everyday life the younger population, those under age 40 or even up to 50, and have them get back to work. Some of them will get infected and will be severely ill, no doubt about it, but the vast majority won't. And then we work very hard to shelter those people who are older, who actually have underlying health conditions that would predispose them to a more serious illness. And that is what we're looking at right now. So Somewhere in between all of that is where reality is and reality will be. Public health measures can have some impact, but it's not a panacea. And as long as there are people out there that are uninfected yet, this virus will keep circulating. And when it keeps circulating, it will find those who are uninfected.
How important is it to have a national strategy?
Well, Lewis Carroll once said, if you don't know where you're going, any road will get you there. And I think that that's one of the problems we're having right now. Part of the issue of confusion, concern, and even people being frightened is that we don't have a strategy as to what to do. We bounce back and forth from one day, for months we say it's very low risk, and then 2 weeks later we're on a war footing. We say we're going to have a 15-day shutdown that'll make a big difference, and we see it's not. So we get to the end of that, and we say, oh well, we'll just end it by Christmas, or I mean by Easter, by just saying we're done. We're going to move on. So I think that that's really leaving people without the leadership and the support that they're looking for as to what to do. The question about putting in place these very stringent lockdown aspects of life in areas that have seen very few cases is surely debatable right now. Do you want to try to apply your actions to do that just as the virus might be coming up in terms of the number of people infected, and not, if it's not there for 2 more months, why apply these during that time? Well, first of all, you got to be certain you can know when that's happening, what kind of data you're going to collect. Testing is not a panacea. We're going to run out of tests within the next 3 to 4 weeks. And I say that in the sense that there'll still be some testing, but reagents right now are very, very, very hard to get your hands on. The whole world is on fire with coronavirus infection. Everybody wants to test. And so it's just not enough testing to go around, and the reagents there. So if you base your outcomes on testing, that's a challenge if you're trying to judge when to put in place these more stringent measures. So we're working on that. What are the other alternatives? New York City actually saw in its influenza surveillance, where they do the surveillance for people with influenza-like illness in a number of doctors' offices, and they add that up every week. And lo and behold, the flu season was coming down 3 weeks ago, and all of a sudden, 3 weeks ago, the case numbers started going way up. Those were obviously COVID-19 infections. They weren't influenza. And we know that testing didn't get into New York until the following week, just because of the absence of it from the CDC. And but once they did, they confirmed that all these transmissions had been going on. And that's kind of where we're at now. We need to find a way to know, how can we tell a community you're potentially about to emerge as one of these hotspots.
When we look at how many hospitalizations that this will cause versus, how many beds that we have, what does that look like?
We're going to be very, very short. The estimates are right now that we just in the state of New York, for example, primarily around New York City, they need an extra 140,000 beds to cover what they think they're going to need to cover over the next month, and they don't exist. Mechanical ventilators don't exist in any meaningful numbers. 3,000 new ones when they need 35,000 new ones. And that's going to be true in many areas around the country over time. I wrote several papers back in 2005 in the New England Journal of Medicine and Foreign Affairs talking about pandemic preparedness. And I said at the time, we were ill prepared for a pandemic. Oh my, if we could only go back to the good old times. We had much better preparedness in 2005 than we do today. Why? We've gnawed our healthcare systems down to the bone. There's nothing left. There is no expansion capacity or surge capacity readily available. Number two, they have not had the funds to buy stockpiles of protective equipment for their workers. Instead, they got used to the ordering method that so many of us do, is going online, hitting a couple of buttons, pressing send, and then having them delivered the next day by FedEx. That's not happening here. Just to give you an example, we are very short supplied already. The companies that make N95 respirators actually started making them in January, full-time, 7 days a week, for 24 hours a day, full speed, in part based on the data we had been providing to these companies. They didn't wait for the federal government to finally decide that it was no longer low risk. Despite that fact, they can produce today, one major company that's been publicly recognized for their production, and they've admitted or declared that they can produce about 35 million N95 respirators a month. That's full bore, all out. Well, one hospital alone in New York City last month reported using over 2 million N95s just to provide healthcare. Now, that's just one hospital in New York. So we're going to be very, very short of mechanical ventilators. We're going to be very short of respirators. We're going to be very short of beds. And we'll be very short of healthcare workers. And so this is not a good combination. And we've been talking about this for a long time. And I think most people just yawned at it and didn't think that it would ever happen. They just had no way of, from their own creative imagination standpoint, imagining this is happening. It is. And now we're stuck with it. Let me just close by saying our philosophy here is that that doesn't mean you can give up. You know, for the sake of my kids and grandkids, I won't. I'm reminded often of the quote of one of our former Secretaries of Defense. He said, when you go to war, you got to go to war with what you got, not what you want. And so that's where we're at today. We're doing that very thing.
What about, you know, there's factories, there's companies now coming out and putting out face masks, putting out ventilators, you know, and I think some people hear that and they say, well, we're going to be okay. They're going to come into production. How long does that stuff take to come online? You know, what's the reality of that?
There's no reality to that at all. This whole debate over the Defense Production Act is meaningless. You know, I've had discussions just in the last week, for example, with major car company leading executives. They remind everybody they don't make anything. They assemble things. They have suppliers that provide all the different parts, etc. They assemble. In that regard, they don't have any expertise in making a mechanical ventilator, which takes over 156 parts that come from different places around the world. And without the machinery to be able to specifically make that little piece, so forth, it's all kind of show and go. I mean, frankly, those that are making mechanical ventilators N95s wish these companies would go away because they're just distracting them from getting their job done when these companies are distracting them because they're being pressured to ask what they're doing. So Ford and GM and others are being said, what are you doing to help out? And in fact, they don't really have much to offer in any meaningful way. And those that would literally going to take us, you know, 6 months to a year before they're geared up to potentially help at all. So I think that, again, I come back to the quote from the Secretary of Defense, you know, this is what we got. This is what we got to deal with. And we're not going to see more. Well, on the other hand, in hospitals, we're trying to push for a much more conservation-minded use of N95s. For example, just something as simple. I have 15 patients with COVID-19. They're in 15 different private isolation rooms. Every time I go in and out of that room, I have to don and doff my equipment. Number one, do you really need to do that? Could you not put them in one large ward where all 15 are there and the whole ward is considered contaminated, and therefore you don't change on and off your equipment between patient beds? Second of all, is you look at this from a conservation standpoint. Do I really need to have 12 people in that room to see that patient? You know, you got all these different doctors, nurses, et cetera, et cetera. Can you cut down on that? And so what we're looking for is both a combination of doing whatever we can to get more equipment. And remember, the whole world wants this right now. This is the problem. It's like with testing. You know, the world's on fire. You know, it used to be a garden hose would be more than enough to supply the reagents we need. Now, you can't even say a fire hose will. We need a tunnel of water, of reagents coming through. And so we're also competing against a whole world that wants these all at once. And that's the challenge. So I just don't see us doing anything other than just adjusting and adapting to the conditions that we've been faced with.
Now, with supply chains being broken, whether it's potentially medicine, food, you know, parts that we use kind of in daily life, you know, like how long, and they talk about the peak and stuff like this, what is the new normal? A lot of people are saying, I'm talking to people, oh, we're just working remote for 2 weeks. How is our new normal going to totally change from what it was before? And how long does that go on for?
Well, first of all, I don't think anyone, again, will look at supply chains with the same sense of security. It's interesting that, you know, when you look at where the primary production of a number of our drugs are, we're coming out with a press release in the next day indicating that we're going to be facing major drug shortages in this country for other conditions, just because China is a very major supplier today of these drugs. On top of that, India, which has basically locked down now, is the other location that we often think about, but they get many of their primary APIs, or active pharmaceutical ingredients, or incipients parts that make up this drug from China. So even though they may manufacture it in India, it comes from China. Ironically, the other area in the world that has a heavy concentration of pharmaceutical industry production is the Lombardy region of Italy. So put those three together and you can get a sense of the challenges we have. And many of these drugs are just-in-time delivery, shortage status all the time. So I think that's just one example, but we have many supply chain examples today of what happened when China shut down. And even, several foreign ministers in around the world, presidents have said, wow, when this is all over, we got to really rethink this thing about putting everything in China. Is that what we want to do? Not because it's anti-Chinese. You want to put all your things in one place anyway, on anything. And you want to spread the risk around a bit so that you can actually deal with that. So I think that's going to be a big change. I think the other thing is going to be people are going to not take these diseases for granted anymore. What this has cost the world, had we invested in vaccine development, research and development of coronaviruses, had we considered better stockpiles, bigger stockpiles of things to protect healthcare workers and the citizens, we could have saved lots and lots and lots of money. So hopefully people are beginning to understand what this investment's all about. When you look at what we do with defense every year in this country, we put a great deal of resources into defense because we don't want to ever be caught short-handed in terms of trying to defend our country. We haven't understood that a greater enemy than an army from without is an infectious disease that comes from within. And what it's doing to our country right now, I think, is a pretty clear indication of that very issue.
Mm-hmm. Do you see us getting, whether it's the U.S. or another country, when this really strikes in a big way, is life get back to normal in a month, in 3 months, in 6 months, in 12 months? What should individuals or businesses expect? Because I think it's very difficult for them to get information, real information without drama or people citing just random, random.
Well, first of all, let me just say, after having given you a sense of our prediction of what's been happening here and been pretty right on, I will be humble enough to say from here on out, we're not sure. Will this play out more where we'll see the virus continue to show up as soon as it's not being suppressed in the population? Will we see the fact that it may come in waves like we saw with influenza, where communities will appear to have beaten it, only to have it come back a second time some months later? We don't know. Clearly, there are only two redeemers here that we have going, and that is, number one, you get the infection, you develop immunity, or you get the infection and you die. The immunity piece, I'm more confident of all the time. There was a study published last Friday from China, which they infected macaques, a type of monkey, who were susceptible to this virus. They got clinically ill, recovered. Then they re-challenged them a month later, and none of the monkeys got infected again, indicating that with the first infection, they did develop some immunity. Now we still have to figure out how long that lasts, what it looks like, but it gives us hope that humans who are infected, once infected and recover, are protected against future infections. What a great resource for our country. They can work in the face of this thing and not worry about getting reinfected. So I think that's one area that we got to look at. The other redeemer, of course, is vaccine. And I've already covered that, knowing that that's going to be a long ways off. It's not going to be anytime soon. But it may be ultimately what we're going to have before we can get back to a sense of normalcy, because if this thing keeps circulating until we have that vaccine, people are always going to feel at risk for developing this infection.
Now, I think that a lot of people, whether it's in different cities or, I talk to people in different countries and healthcare and governments kind of almost every day, there's always we don't have any cases, or we just have 10 cases. Mm-hmm. So I think it's we're talking about the problem with test kits or even confirmed cases. It almost seems like it's a trend of, well, that was China, and now that's Italy, and now that's US, or that's New York City. What is your opinion on that when people take that approach of, well, it's not going to come here, or it's not going to be bad here?
Well, I think, again, look at the fact that we did go through an entire month of February. Everybody kept saying, see, it's not coming to the United States. And look what happened. It's not going to the rest of the world. Look what happened. Even here with seasonal influenza, just using that as a model, many of the small towns around rural America often are some of the worst hit communities in the winter with flu. Nursing homes are shut down, or visitors are prohibited from coming in. Hospitals are overwhelmed. They may be the very last to get hit just by population density and movement of the virus. I don't think any community can say that tomorrow couldn't be our time. And I think that in many instances, as infectious as this virus is, that's exactly what's going to happen. Exactly.
What should people be doing? I mean, you talked about, the social distancing, social responsibility. What are these things? What you said, whether it works or doesn't, what's your advice to everyone?
Well, first of all, you have to be responsible for yourself and your family. I think people who believe it's government's role to protect me are going to be the ones that are going to be most impacted, because they're going to be irresponsible to the extent of getting readily infected. And what now, if you are someone who, I will say, over age 55 to 60, some cutoff, if you have underlying heart disease, if you have had cancer and certain treatments, if you've had renal disease, chronic lung disease, or you're obese, those are all risk factors for developing this acute respiratory distress syndrome with this kind of pneumonia. So you have to protect yourself. If you go out in public places, know that you're going to be at risk. We're not recommending you wear any masks, because the surgical masks we put on our face do not really have any impact on this virus going through the side vents where, it's open on the face. People who have beards, you, for example, couldn't wear one of those protective devices with your beard. And so, in a sense, we say, that's what you're stuck with. We do not recommend N95s on the general public. We've got to save them for healthcare workers. Okay, that would be like, denying somebody who's on the front lines of a major police department pulling off a drug raid tonight, not having a vest because, 3 people who went out to dinner in a nice suburb of some city wore them just on the off chance something might happen. So we've really got to save these for healthcare workers. So I think the bottom line is you have to take care of yourself. Now, we can help take care of people, meaning that if you have that 80-year-old man or woman living across the street that are alone, that don't have somebody to help them out, that's where you very definitely can be part of their life by not talking to them by sitting down with them, but on the phone, by the computer. Many of them have computers. Running errands for them. Go to the store for them. And only if you've been infected yourself and fully recovered can you then go and have contact with them, and then you can have all the contact you want. So I think it's how to figure out what to do good things. One of the really outstanding efforts right now was started by a group of second-year medical students at the University of Minnesota. As you may know, first and second-year medical students are just that, students. They're not ready to go on the wards and do service. And right now, their classes are all shut down. And so the challenge has been, what do? Well, they've organized themselves. So for many healthcare workers, when schools were closed, found themselves needing to provide childcare. They have kids, 20% of nurses have kids in between K to 12. And so at that point, this group got together and signed up, went through the appropriate clearances, and are making themselves available around the country now through a whole network of medical students to babysit during the day or whenever for healthcare workers that then can go to work. So there's many different things you can do like that that would be very, very helpful. And I think that's the kind of thing to look out. The last thing I would just say, if people do self-isolate to protect themselves, loneliness is horrible. Don't let people be lonely. Reach out. That's why I don't like the term social distancing. I like physical distancing. Be physically distant, but don't be socially distant.
What if, I have a neighbor who his wife is in her 60s. She has cancer. She's going through chemo once a week for 52 weeks, has to go to the hospital. For people like that, should they be going in with gloves, masks? What should they be doing, to avoid catching COVID-19 when they go to the hospital?
Hospitals need to take that into account now. We do that all the time for people who have measles, chickenpox, etc. How do you keep them from infecting others? Well, when you have a lot of COVID in your hospital, you're right. Now it's kind of reversed. it's turned on its ears. Now you're trying to protect the few people that come in, not all the people that are there. And a number of hospitals are doing a lot about that, trying to find safe entrances for people who don't have it, but making sure that when somebody says they don't have it, they really don't. I mean, one of the big outbreaks that occurred in China in a healthcare facility was related to a patient coming in having eye surgery done, didn't feel quite well that day. They intubated him, which only spread the virus more, and 14 people in the surgical suite all got infected from that one patient. So, no one knew he had COVID-19. So I think that at this point, we got to do the best we can to make sure that, we protect these people both in their homes, but also in these healthcare locations. And I think everyone is making an effort to do that.
Great.